He is Mike, the son of a friend who came into practice a few years ago. I usually see him fooling around with my children at dinners, but today he's not smiling at me. I know his mom has undergone orthognatic surgery, so his profile does alarm me a bit, but I want to check the position of the teeth first before doing anything else. Those intraoral photos show us an anterior cross bite, aside from the radicular remnants from 54 and 64. Nonetheless, I choose to wait because I think his upper incisors might come up to a normal position. Well, at this point, there was no actual reason to believe the crossbite would get solved by himself. So, I prescribe him a palatal expander associated with a face mask. The mask starts pulling the maxillary bone forward and downward, following normal growth direction. After 6 months of hard cooperation with the mask, Mike has helped me in solving his anterior crossbite. There is not much left to do, so I remove the expander and I tell his parents to show up every year to check how his teeth would be erupting. But before we go on, I have some thoughts to share with you. First, literature suggests that we have a better response to face mask treatment at age 6 or 7 than at age 9. So, we'll surely get more dental effects than skeletal ones, and greater relapse. Second, the first thing to do before using a face mask is checking if there is an actual class 3. If you have a skeletal class 1 and an anterior crossbite, you could solve the problem just with brackets. But Mike's mom has undergone surgery, and we know that there is some evidence of inheritance with third-class problems. And most of all, Mike is the son of a friend, and I'll give you my evidence you better not take risks in these situations. Anyways, the take-home message is, do not panic if you see an anterior crossbite at age 7. Check the lateral X-ray, the profile, the bite, and the inheritance, and then choose the appropriate treatment. I follow up Mike for another couple of years, waiting for the permanent dentition to show up. As you can see, these incisors just do not want to cooperate. The lack of space is one of the reasons for this crossbite, but what is also responsible is the length of the mandible. Okay, we then bond another palatal expander to give some space to the dental arch. At 12 years old, we can still obtain an opening of the median palatine suture, but we will also get expansion from posterior teeth tipping, which is unwanted, but is also inevitable. Well, it is not inevitable if you use full bone-borne palatal expansion, but that's the topic for another video. This expander is provided with coils to pull 12 and 22 a bit forward while also expanding, but make sure your dental technician builds it wisely, because in case of interferences, the teeth will not move. This is the situation after bonding the upper arch. As you can see, we did not bond the lateral upper incisors. Instead, we bonded 2 palatal buttons and we attached the power chain from the canine to the button to the central incisor. This mechanic will get them in arch in no time, but the power chains tend to close the space for 12 and 22. Now, to keep it open, we use a passive open coil spring. You could also bond the brackets on 12 and 22 straight away, but the risk is that the contact between the brackets and the lower arch frequently makes the brackets fall off. Also, this way, you would need posterior bite turbos way earlier. As you can see, this kind of mechanic has a counter effect. It gives a lot of positive torque on 12 and 22. So, when bonding the upper arch, we plan on placing these brackets upside down. This way, we can keep the same tip, but we get an opposite torque, which is very useful here. But of course, These are rectangular slots 022. We won't get any torque until we get to a rectangular arch wire. So, with a 016 Q-Night tie wire, we get some alignment, but no torque expression, as you can see from the lack of bone where the roots should be. We can then engage a 14 by 25 Q-Night tie, an 18 by 25 Q-Night tie, and eventually a 19 by 25 SS, which starts to make some torque effect on those teeth. You can see the roots are slowly appearing. After 5 months, on a 19 by 25 SS, we get a full torque expression. Clinical crowns seem longer due to a more vertical tooth axis, and we can see a beautiful root profile. After debonding, we get a good torque on those lateral incisors. But the gingival retraction on 12 tells us we may have gone a bit too far. Keep in mind that hypercorrection in these cases may be a good idea, but also notice the whole lot of torque expressed by a 19 by 25 SS arch wire that has been kept there for 5 months. Mike also got some nice resin reconstruction over 11 and 12, which has ruined incisal margins. Yeah, we can see he's still a dental 3rd class, but I don't think he's aware of it.